Hello, everyone. Welcome to our weekly session of Vitra Global Spine Conference. This Thursday, I have the pleasure to host a friend of mine from Brazil, Dr. Nelson Astur from Sao Paulo. He's a spine surgeon at the Albert Einstein Hospital. For those who don't know, Albert Einstein Hospital is ranked #1 in Latin America. It's the best hospital in Latin America. It's a huge hospital, and they called for the best surgeons. So Nelson is one of the best surgeons in Latin America. So without further introduction, Nelson, thanks for being here and for talking to us for Vitra Global about this very interesting topic of competitive sports after spinal surgery. Thanks, Nelson.
You're welcome, Alfredo. Thank you for the nice presentation, and also for inviting me for this great thing that is the Viral Spine Conference. And well, thank you for the presentation. As you said, I'm an orthopedic spine surgeon based in São Paulo, born and raised in São Paulo. I spent some time abroad too, and currently I'm the Spine Fellowship Program Director in Hospital Albert Einstein, and I'm also the Latin America AO Spine Research Officer. I also work in a private clinic called Instituto Coen, where we treat a lot of athletes and sports. We are very known for the knee surgeries of the Brazilian soccer players. But I only do spine, so I'll talk more on spine. So yeah, so we choose these topics, competitive sports and spinal fusion. After spinal fusion, we see that very interesting. We don't see a lot of people talking. There are no specific guidelines. We mostly do personal guidelines based on experiences, and we try to publish things on that. So I thought that it was a good topic to bring to Viral Spine. And yeah, so let's do this. Okay, so those are my disclosures. They are not related to this specific talk. And well, I want to start with a clinical case to bring on the topic. So this is a male patient. He's 30 years old. He's a gymnastics athlete, a professional athlete. He was silver medal in the Rio de Janeiro Olympics and 2 times world champion. So after the Olympic Games, he comes to our clinic complaining of severe back pain, 3 years of low back pain. And he's been training and competing with big back pain, severe back pain, with no response to clinic on physiotherapeutic treatments. He had a partial response to facet joint injections in the L2, L3, and L4 levels, where most of his spinal abnormalities are, his degenerations are, and he's very limited for training, social, and daily activities. So he says, after coming back from Olympics, he says he's not able to compete professionally, but he still wants to go to the next Olympic Games, which was Japan, Tokyo. So in his physical exam, he has back pain worsening with trunk extension. There's no irradiating pain, no leg pain, no neurodeficits. And that is his CT. You can see a lot of degeneration for a 30 years old patient, but he's been doing gymnastics since he was 8, 9 years old. So you see a lot of disc degeneration. You see a lot of pars fracture. There's a L5S1 spony with an ischemic spony. And also, most of his disc degenerations are on the L2-3 and L3-4 levels. And there's also this MRI. You don't see a very severe canal stenosis or nerve compression, but a lot of spondylosis, a lot of arthrosis. So yeah, I want to start this with this case to bring on the topics. We have an athlete. He wants to go back to Olympic level. We don't know how much surgery can help him. Should we do surgery? Should we keep on treating him conservatively? He's a very strong guy. How surgery will impact his career? So if we are doing surgery, what levels, which technique? Is he going to return to sports, right? Do you want to take a peek on this, Alfredo? Want
Well,
to try bring it on to
I don't know.
discussion?
Yeah, that's a pretty tricky question. I mean,
It's hard, right?
yeah, I don't know. I don't think a small surgery can deal with all of these problems. I don't really know where the problem came from or the pain came from. As you said, probably came from the apex of that deformity to 3 to 4.
Yeah.
But they also have a spony at 5-1, and what I do know, like long fusion will take out from sport forever, like
Yeah.
a T10 to pelvis or L2 to pelvis or whatever. Maybe you can treat the apex of the deformity, but I don't know if that can impact on his performance being an athlete. I mean, probably all
Yeah.
these lysis came from the hyperextension movements he does when he trains. Um, I will probably offer that to fuse the apex, maybe laterals and perks and or something like that. And but I cannot assure that it will be back to the next Olympics. You know, I don't know. It's pretty
It's
tricky.
yeah, no, it's so many questions, and most of the answers are I don't know, right? You you
Yeah.
you you talk to the patient, you have to align the expectations, and he wants to go back to a level that you maybe you cannot promise if he's going back. And also, if you go for big surgery, you may be retiring him from his career, especially in a sport that there are a lot of motion and you need all the range of motion from his lumbar pelvic junction, especially on the L5S1 junction. That's where we were most afraid of fusing him. And well, I'll just show how it ended up later. So bring up some concepts and some principles, and then we'll come back to the case, right?
Awesome.
So in this presentation, we are going to go over these topics: the strategy to return to play, the types of sports, and the relationship of each sport with specific injuries related to it, how fusion levels may impact of an athlete's performance, if there is a change in surgical technique for each case, and the differences of degenerative and deformity cases, and how a professional career may impact on our medical decision-making process. And in this presentation here, as you can tell, those are major athletes that have stand out greatly within their sports, and all of them have a common story of back injuries during their careers. Some are related to trauma, and some to degenerative spine problems. Some needed surgery, others not, but they kept on their games. You may recognize some of those. The one on the top left was very dramatic for us Brazilians, right? You may remember that, and I still blame the Colombians for that. And the opposite side, on the lower right side, especially for overseas participants, that is one of the most important volleyball players in Brazil. He was a gold medalist in Athens 2004, silver in Beijing 2008, 2 times world championship, a lot of championships, and he was an MVP. And in 2010, he had an L4-5 fusion here in São Paulo, and he kept playing for 10 more years after that. And after that, he was silver in London and gold medalist in Rio 2016 and MVP in that competition. So you see that fusion will not retire you from your career. And At the same time, aging is not necessarily a retirement for these players, as and as their longevity grows and they will keep competing under their 40s, and we are dealing with more degenerative changes. So they still want to keep on being bigger, stronger, and faster, and won't stop even with a spinal fusion. But in the big picture, those are exceptions, right? We're not only treating superstars and their professional athletes, but also people with other jobs, but that do really well on their recreational sports, and sometimes with the same physical demand as a pro athlete. So there are different types of athletes, and in our medical offices, we are seeing high performance professional athletes, high performance amateur athletes, recreative athletes, young athletes, senior athletes, women athletes, and also Paralympic athletes. Each one of them will have different needs and goals to be discussed when making a treatment decision. And they will also have a broad spectrum of body types that may influence your fusion strategy. Those in the pictures are all professional athletes that stood out in their sports. This picture is in the Olympic Museum in Lausanne. I don't know if you have the chance to be there. It's a great sports museum in Switzerland. And when you're there, one should guess which sport each one competed. Also, I just wanted to point out and bring this TV reality show. I'm a big fan of the Physical 100 that is running on Netflix, and that shows us how different athletes can be, and a professional will not always be a recreational athlete according to specific physical demands. And we know that professional athletes are constantly doing repetitive movements and loads in their practice, and tend to develop specific injuries that may speed up the degenerative process. Pain should impair their performance, but it is within their essence to overcome challenges, and with their high basic physical fitness, return to previous activities, or they are just highly motivated to keep competing even in painful symptoms. And when fusion is needed to treat those conditions, it should be discussed as a treatment plan to get back to a competitive performance, and not as a contraindication for further sports activities. And at the same time, we as surgeons should understand that spinal surgery in professional athletes is a special category of treatment of pathology following extreme and often prohibitive loads. So, and if sports activities are based on motion, shouldn't a fusion procedure be paradoxical to it? But with all the innovation and technology to lesser invasive procedures and muscle damage, we may be trying to improve the performance sometimes with surgery and not necessarily retiring a player. And as we have repetitive higher loads in the spine in sports, even performing less invasive surgery, we should aim to strong, solid fusion masses to stabilize and hold constant collision and impact. In this concept, interbodies are very useful. And I would personally recommend, whenever possible, using anterior or lateral interbody fusion that will have the bigger cages with larger footprints and that are for solid fusion, and will also share load better in the vertebral end plates. And anterior and lateral approaches will also preserve core muscles essential to sports performance, not ripping off important posterior muscle fibers. And the association of posterior support with screws is also recommended. Perk screws will do a better job in muscle sparing too. This is an example of a CrossFit competitor that I treated. He had an acute extruded disc herniation that was operated with a tubular microdiscectomy previously, and 1 year later developed a painful disc degeneration that prevented him from competing. So aiming for a lesser invasiveness, we opted for a single anterior approach and a standalone A-lift that feels it really solid, but it took him almost 1 year to fully return to his performance. And even though with moderate back pain. And I still wonder if associating posterior perc screws in this case would bring him more stability, earlier return to play, and also less back pain. So, and having said that, all these concepts, we must understand all categories of sports in terms of physical load, and we'll basically divide them in non-contact, contact, and collision sports. Loads and movements will be different for each one. You can see swimming, golf, tennis, running, sprints are non-contact sports. Contact sports would be soccer, basketball, volleyball, team players, right? Team sports. And there are the collision sports, mostly represented by American football, hockey, rugby, martial arts, wrestling. Yeah. So, and we as surgeons, we must share all possible drawbacks from the fusion procedure and align patient expectations, especially when it comes to competitive performance. And at the end, most of them will likely find their way back to sport, maybe not at the same level. And what I can tell is that professional athletes with team contracts will mostly follow the surgeon's advice, opposite to recreational athletes that sometimes will do their way. And that is why we must always tell them the consequences of not following the proper post-operatory restrictions. As far as recreational sports, this author analyzed 32 practitioners of different sports with one or multi-level fusion, and there were different timings of return to play. Biking had a mean time of 3 months, swimming 5 months, and golf 8 months. And surgery actually increased the amount of swimming and biking, but on the other hand, decreased performance on golf, possibly related to the respective sportive gesture. This is an example of a recreational high school competitive swimmer I treated. He had adolescent idiopathic scoliosis requiring surgery and a long fusion. So we had a D4L4 fusion, as you can see. And since there was no loads or impact, he wanted to go back to the swimming pool. We started water rehabilitation and exercising and practice within 1 month of surgery, and he did pretty well. So if he tolerates pain, especially in his crawling technique, I don't see a problem that would damage your surgery, your fusion structure, right? As far as timing of return to play, it is not clearly established. We are mostly aware from contact and collision sports. Some will say there is no return earlier than 4 to 6 months after surgery. And a survey among SDSG members published in 2015 gave the recommendations of 3 months for running activities, 6 months for non-contact and contact sports, and collision sports are always controversial. While some recommended a minimum of 12 months, 20% forbade return to collision sports after AIS surgery. And a Russian publication with 27 pro athletes with min 4 years follow-up with sports such as weightlifting, skiing, boxing, football, and tennis had a mean return to play after MIS lumbar fusion of 3 to 4 months. That will also bring us this data that MIS fusion will bring an early recovery to return to play. And distal fusion levels always also plays a role in return to play. especially in deformity surgery. It is also decisive as a predictor of successful or return to play. 73% of patients with a T12 fusion, distal fusion level, return to their previous activity compared to only 20% of patients with an L4 distal fusion level. And L4 was also decisive for experienced surgeons from the SDSG group in a questionnaire-based survey to never allow return to collision sports, those for AIS patients. And there's also a lot of research on golf and spine. It is a non-contact sports, but with a lot of lateral shear, bending, compression, and torsional forces, though. That's that's part of the routine swing of golf. And after spinal fusions, golfers may have to adjust their swing with a limited bending and twisting of the lower spine. And Shiftlet reported 34 golfers with spinal fusion with a mean age of 54 years of age, and there were where half of them returned to play, and half with decreased pain while playing, while showing also increased performance. They return to play 6 to 12 months after surgery. Also, in this survey of 523 spine surgeons on return to play for golf, the recommendations were 4 to 8 weeks after a lumbar decompression, 2 to 3 months after an ACDF, and 6 months after a lumbar fusion. And they also reported that competitive golfers may present a shorter return to play. Hockey is also very publishable. Greg Schroeder has a lot of data among American hockey players and the NHL. He reported among 87 NHL players with disc herniation, and 31 were treated non-operatively with a return to play rate of 90%. 48 needed a discectomy, and return to play rate was 82%, while only 8 players all this period needed and had a single level fusion, and all of them kept playing for over a 4-year period. While there was a significant decrease in performance score, the fusions group of players did not show decrease in games played or performance score after surgery, which is very impressive. It's a small sample, but showed a very good result. So what about kids and teenagers? They mostly frequent the cause of their low back pain and eventual fusion is spondylosis and spondylolisthesis. Well, it should be treated conservatively with mostly good results. But when fusion is needed, Radcliffe proposed a return to play plan of 2 weeks of core strengthening, non-impact activity at 2 weeks, exercises with neuro spine for 3 months, and higher impact activity at 3 months. Return to play when normal strength, range of motion, and no pain with sport-specific activity is achieved, right? So, and that will mostly come within 6 to 12 months after surgery. And an SRS, the Scoliosis Research Society member survey on return to play would recommend return to play for low impact non-contact sports by 6 to 12 months for most of the participants. Contact sports, I'm sorry, yeah. Yes, there is. So contact sports would require 1 year, and collision sports or with repetitive load were discouraged by most of the members. Fusion for spony in pediatric patients should be allowed return to play usually within 1 year of surgery if they are asymptomatic, achieved stable fusion, and are fully rehabilitated to their previous playing capacity. So what about surgical adolescent scoliosis? Can they return sports with the same level of performance? Does it changes if it is a non-contact or contact or collision sports? Distal level probably has an impact, as we said, and what is the time to return to play? So another case I treated, this is a 15-year-old male with adolescent idiopathic scoliosis. He's a Taekwondo fighter. He's trying to apply for his master's degree. When he became I don't know the term for that, is like he's a teacher or a master in Taekwondo. But at the same time, he had his surgical scoliosis, and he needed fusion. He was growing. There was a progressive deformity, so we couldn't just postpone surgery. We had to do surgery, and so we did a T4L4 fusion, and after 1.5 years, he had his graduation for Taekwondo. As you can see in the video, he can do most of the movements. Besides, although he had a limited range of motion, he can compensate with his hip motion and his trunk swing, twisting. And there's another video he sent me of him doing all the graduation exercise. That was during the pandemic. You can see they all have their masks on. So that's a good example that a long fusion construct would not prevent him from graduating. Pretty impressive. Yeah, he just sent me
he's
that.
He's really a fighter.
Yeah,
against the Scully, against the teachers.
Yeah, that's
Scoliosis fighters.
Yeah, scoliosis. I try to share that on SRS with the social media group, but we needed terms of TCLLs from all the people in the video, so it was impossible to get those. All right, so okay, so AIS fusion is a long construct, as I said, and will decrease range of motion, spine range of motion, but a return to play is possible. And in 2012, 42 athletes with posterior spinal fusion for AIS that returned to their games were studied, and they needed a minimum of 4 months and returned when there was no pain and radiographs were okay. And mean time was 7 months. Almost 60% returned at an equal, higher, or an equal or higher level of participation. Some complained of loss of flexibility, back pain, or deconditioning. And distal fusion level was truly related to return to play, with 73% of T12s distal fusion level returning, and only 20 of those with an L4 as a distal fusion level. Another survey on return to play and AIS, only 32% of surgeons would allow return to play for collision sports. That's very, very controversial. Running is allowed by 3 months, non-contact sports by 6. Ultimately, the decision to allow any young athlete to resume sports participation after spinal injury or surgery must always be individualized, right? Individualized. And there should be a plan for AIS and return sports based on all previous studies, on the society studies and surveys. No heavy lifting or repetitive bending for the first 6 weeks. We should encourage them walking for the first 6 weeks. Backpacks and lifting up to 10 pounds allowed after 6 weeks. Most lifting restrictions removed after 3 months, and return to more vigorous training for sports and progression to sports beginning at 3 months. All right. Yeah, so this is another good clinical case. Let's see. I can't see who's online, Alfredo, so if you can help me choosing people to participate.
There's a lot of people. There's Alexandre Carvalho, a good friend of us.
Oh
He's
yeah,
connecting. He's doing asking. He's doing questions. So,
good to hear from.
can you? Yeah,
So yeah,
he
just
did
present.
an. Yeah, if you wanna answer the one of the question from Alexandre first, um,
Oh, I don't see the
he,
questions.
let me look
Let
at
me
it.
just open this.
I not see
Okay.
this. He can do the question live. Are you there, Alexandre?
Hi,
Oh,
hello.
Yeah,
Hi, Alfredo.
yeah. Hey, buddy, how are you?
hi, Alexandre. How are you, man?
Hi, congratulations for your presentations. Nelson, I have questions. In practitioners of physical activities with low or impact, how do you level adjacent 360 degrees fusions behavior? If there is a high prevalence of degenerative disease in this group of patients, or is respect the alignment parameters, we still the most important factors in determine a degenerative process in these patients? What do you think about it?
Well, those are mostly the rules for regular patients. We should always respect alignment. We should provide them a good fusion. As far as athletes, they will always have a higher load, but not only alignment, but especially the sports they practice will bring uh, two scenarios. Maybe they will have big loads or repetitive movements. Let's say golf, for instance, a lot of twisting. So it's not much about loads, but twisting in the adjacent segments. And if the fusion is within this segment, there is probably a higher chance of progression of degeneration. Load sports, impact sports will mostly lead to faster process of degeneration of the adjacent levels. But at the same time, when you're talking to a competitor, especially a professional athlete, he's not much worried about what's going to happen in 5 or 10 years. He just wanted to be back in 6 months maximum so he can compete because that's his job. So that's the same thing we think when we're treating knee meniscal tears in soccer players. You don't want to suture your meniscus because you know you're putting him out of the game for an year maybe. But if you just take off his meniscus, he will be back in 2 months. So he's not very worried about degenerative disease, adjacent degenerative disease, as long as he's back in, let's say, 6 months. So I know we as surgeons, we are worried about that. We are worried about the next 10 years, 15 years. But as a profession, they don't care much about that. I know it's cruel, but that's how it works. They just want to go back to the next competition, to the next Olympics. So that's how you got to think different, right?
Okay, I understand. I understand the athlete it's completely crazy.
But yeah, I know, and it's a combination of factors. Spinal alignment, it's fundamental, but at the same time, you cannot just add three levels to get the optimal alignment. Sometimes you have to accept a suboptimal alignment to save fusion levels, thinking on his movement. Just like the case I presented first, if we do a whole fusion, I don't think he's going back. He's returning to sports. So we need a very precision, accurate diagnosis of the pain generator to treat him and put him back to competition, right?
You talked about the importance of the muscles,
Yeah.
posterior muscles, especially in athletes. In which patients do you prefer standalone procedures without percutaneous pedicles screws, especially because the athletes usually has so many activities and movement?
Yeah, no, that's a good question. I would say all of them for two reasons. First, axial load. If you have a standalone A-lift, for instance, even if you have a solid bone fusion and you start to have axial load, what I see first, they will take longer to return to play because there will be some movement on the untouched facet joints in the back, and it will take more time for them to return. And also, if they are practitioners of repetitive flex extension sports movement, there may be minimum movement on these facets that may cause pain or may fail, may get your fusion to fail. So I always go for a better support. And if you're going with percutaneous screws, you're always also sparing those back muscles. So I would mostly use percutaneous screws for, along with my anterior fusion for this
Okay, thank
patient.
you.
Awesome, Nelson. I have a short question. I mean, I don't know if it's short. You just show how lower instrument vertebra change the return to play time frame. I mean, it's not the same to stop at L1 or T12 like to L4 or the 3L4. So do you have a different talk with the kids and the parents about doing more selective fusions in those cases of pro athletes or intense athletes, respecting the lower instrument vertebra, or you do as you think it's needed? You fuse L3 to L4.
Yeah, and we will talk about this, but what I can tell you is, first of all, it's hard to make that decision with kids because you don't know their future. You don't know if they're going pro, if they are doing there for a living as a profession. And the parents also don't know, and they mostly tend to support their kids with their dreams. So some things you have to consider is their early goals. Let's say there's a competition, there's even an Olympic Games, and they want to go there. There's a good case of I don't remember her name, a swimmer. She had progressive scoliosis. She needed surgery, but they decided to postpone surgery so she could go to the Olympics, the same level she was practicing. And so they postponed the surgery. They did surgery with a higher curve, a bigger curve, but she could go to Olympics. So timing is also important in your decision-making process. You have to consider that. And if family is okay in doing surgery, and I can tell, I can give the same good result on a 50 degrees curve or a 65 degrees curve. So, and competition is very important to these kids. But at the same time, you will tell them that they will probably decrease their performance according to sports after a long construct. Selective thoracic fusions will provide a higher rate of return to play. And you may consider that if you have a compensatory, let's say a Linky 3 curve with a compensatory type, even a type C curve, that you may not want to correct completely in its first surgery. There's a risk of progression, a risk of add-on, but you put that in your balance and share that with family and the patient, and share expectations that you may come back in the future for a new surgery after her competition is over, after she's retired from competition, right? And this is a good case. We can discuss that. It is
Awesome.
You want to ask something, Alfredo?
No. Go.
Yeah. So this is a 17-year-old athlete. He's a Paralympic table tennis athlete. He placed third in a world championship in 2022. He had his past history is he had a spinal cord tumor operated at 1 year of age, multiple spine surgeries. When he was younger, he started his treatment in Brazil. Then he went to the States, I think MD Anderson maybe, where he did 2 or 3 surgeries to remove a cord, resect a cord tumor. And he was fine, he was treated, but he became severely myelopathic. He can stand and do small, he has small gait ability, but he is a wheelchair dependent, and he started developing a neuromuscular scoliosis that progressed a lot during the pandemics and also during his growth spurt. And he came to me with a 90 degrees lumbar, very rigid scoliosis with pelvic obliquity. And he also sent me some of the videos of him playing, so I could understand his movements, his sport, what he needed to keep on playing. And he told me, I don't want to quit. That's my dream. I want to become a professional player. I want to play the Olympics, the Paralympic Games, right? So we had a very rigid curve, progressive curve, 90 degrees with a pelvic obliquity. And what would you do? What would you do? He came to me, and some other surgeons just said, well, you should give up on this. It's not for you. We need a full surgery here. What are your thoughts? Alexandre, well, any thoughts on this? Or maybe other speakers. Anyone else wants to speak up on this?
Also, only co-hosts can speak. So there's you and me, and Alexandre, I activated his microphone.
Oh, okay.
But I will do, I mean, he needs surgery.
Yeah.
It's a very severe curve and will progress. That's for sure. So, I mean,
let me ask you this way, Alfredo. Let me ask you this way. If he was not an athlete, just neuromuscular scoliosis that came into your office, and with this curve on a wheelchair, what would you do?
To defer to pelvis and try to restore the pelvic obliquity and try to not overcorrect the hyperlordosis, to give him the ability to sit properly. That's what I do.
Controversies, right? Not a lot of controversies.
Pretty straightforward.
So he tells you that I want to keep playing. I want to compete. I want to go to the Paralympic Games, and he shows you this video, and what you can do for me, doc. I don't want to quit. Would you change your treatment plan?
I mean, probably no. I mean, maybe I stop a little bit lower in the thoracic spine to don't affect the ability to move the upper limbs. But my main surgery will be probably the same. If I get a good correction in the lumbar spine, but I don't think I can do that. I maybe stop at 4, but this with that PO and that curve, I probably go to the pelvis.
Sure. Alexandre, you wanna any thoughts?
I agree with Alfredo. It's a complex case, is difficult decisions, but I think the best options in this cases will be T2 pelvis.
Yeah. So that's you're too correct. So my thoughts on that when I had this case was, well, this guy needs forward flexing. He needs pelvic movement because he's always going for the ball. He's flexing forward on the table. He needs a lot of shoulder movements too. And at the same time, I wanted to provide him all this mobility, but I couldn't deny that he needed a big surgery. So I discussed that with family of how much correction I could give him if I didn't included the pelvis in my fusion. Then I told them I'm not gonna have a good pelvic obliquity correction that may affect the way you sit on your wheelchair, but at the same time, I will maintain your lumbar pelvic motion so you can go back to your practice and to your competition. And I discussed that we may go back in the future for a new surgery to include his pelvis. So that's just the discussion we had earlier about sparing levels to keep them playing, and then we come back for maybe a new surgery in the future. So yeah, that's what I did. You see, very rigid curves, a lot of previous surgeries. I just worked with posterior osteotomies, not anterior osteotomies. So not a huge correction on his lumbar curve, but he was well balanced. A little improvement on his pelvic obliquity, but we still have a pelvic obliquity. That's his clinical appearance after surgery. He was very happy. He was very strong, so rehabilitation, physical therapy was easier. And my post-op plan was at 3 months, he started practicing only serving, just arm movement, no flex forwarding. I was worried about all the screw loosening. I wanted a good bone fusion. At 4 months post-op, I started forehand and backhand without forward bending. 6 months, I had a CT. I had a good bone fusion, although in the L5 screw, there was some screw loosening. I was pretty worried, but the other side was fine, and he started developing bone mass around the screw set. And so I was confident that it was fused. So he went back to full practice, full training with all the movements. He's in the Brazilian national team, Paralympic team. That's him practicing. And well, happy ending here. Last year, he was he had 1 gold medal in the Paralympic Games in Santiago, Chile, and 2 silver medals last year. So he's making his way to Paris this year, to the Paralympic Games. So yeah, so we may go back in the future for a fusion, right? If you want to follow him, that's his Instagram account.
Awesome, but
Yeah,
at
that's
least
an example of
he can do that.
how we change strategy in
customize the treatment.
Yeah. There are some questions here, Fredo, if we want to.
Yeah, Alisa Hoffman asked if you test bone mineral density in these wheelchair patients prior to surgery. That's a very good question. We know these patients are typically osteopenic or osteoporotic. And if you change the strategy for surgery, if you do bigger screws or longer screws, and about the loosening, but you just mentioned that.
Yeah. About on bone, BMI, I was not worried, especially on those young patients. We know that they are wheelchair patients, but they are so active, they are so strong, they develop such a strong core and trunk muscles that you don't see osteoporosis or bone weakening. If you have any doubt, you may go for it, but it's usually not a problem, right? Awesome. And about diameter and long screws, it's the same thing I do for regular patients. I always try to go bigger and thicker screws based on pre-op CT and mostly based on navigation. Since I have navigation, I will also improve, optimize my screws size so I have a better purchase. And screw loosenings, yes, we see them over time, especially during their fusion time. And this patient, he wanted to go back, and I was trying to stop him. So I wasn't letting him doing forward flexing and everything, but of course he was doing that and not telling me. So, and I showed him, you see, you have one screw that is loosening, the other one is good. If you lose the other one, we're gonna have to go back to the OR. That's what I told him. I told him, you're on a plane, one of your engines is down. If the other one goes down too, we're gonna have to land. Then we go back to the OR and you lose your time, recovery timing. So you have to alert them. If you don't, they won't stop. Especially those athletes that depends on their playing. They don't have a contract. It's not like they are a professional player that even if they are injured, they will still have their salaries. A lot of those in soccer, right?
Yeah, exactly.
Very. Yeah. So oh, Michelle just remind me. That's the Australian swimmer. Michelle works with me, and she had scoliosis. Jessica Ashwood, 13 years old. She had an over 40 degrees double curve. She postponed surgery until she was 26 years old. When she stopped to swim professionally, then she went to surgery. That's the athlete I was trying to remember. Thank you, Michelle. Thank you very much. So, okay, let me go back to the presentation. Yeah, I want to go briefly to cervical fusion, return to play after cervical fusion, especially ACDFs. That's a big problem on collision sports, especially in North America and in States. This is a non-review of 26 athletes from NFL, NHL, MLB, NBA undergoing ACDFs, and 80% returned to play with a mean time of 9 months. And those who returned kept playing for a mean time of 3 years. ACDFs is a problem, and we should be aware of it, especially on those collision sports. This is a meta-analysis of 48 elite contact athletes that reported return to play rate of 73 after an ACDF. And in 2006, there were these recommendations for return to play after an ACDF. One level fusion is okay to, especially for American football. One level fusion is okay to return to play when they are asymptomatic. 2 to 3 levels fusion would be a relative contraindication. And more than 3 levels of fusion, an absolute contraindication to return to play, especially to collision sports such as rugby and American football. Furthermore, there is this consensus published in 2020 reporting the risk factors for awareness for return to play. Myelopathy symptoms, cord abnormalities. There should be no edema. There should be heel edema or edema. It will affect your decision. The canal diameter, stenosis, the number of levels fused, just as I said. If there is non-fusion, if there is a pseudarthrosis, if there is any sign of stability, if you perform the corpectomy or a posterior approach, there's also risk factors to get your athlete back to play. Okay, so let's go back to the case we started. Any tackle on this? So you said, Alfredo, you said you would go for the apex, right? But there's also these L4, L5S1 spony.
Yeah.
So yeah, go ahead.
No, I go. If the symptoms match with the images of the apex of the curve, there's no sciatica or nothing related to L5S1. I go to the apex. I have the conversation that I can promise him to get back to sports, but it's more likely to be back if L4, 5, 5-1 are free than if they're fused.
Yeah, we had so much discussion on this case when it came to us. What should we do? What are the expectations we should deliver to him? There's no question he's very strong. Look at the size of his psoas. He tried everything, physiotherapy, we did injections, they had limited results. And we diagnosed his pain generator as the levels 2, 3, and 3, 4, where there was most of the modic changes, the listhesis, and all the pars fractures. On the physical exam, there was not much pain on his L5 S1 level, seemed to be very stable. And at the same time, we knew that if we fuse the L5 S1, we'll probably decrease his chances to go back to professional sports. And remember, he wanted to go back to Tokyo, right? He wanted to be in Tokyo. So yeah, so we decided to L2, L3, L4 fusion with a lateral approach, lateral fusion, and percutaneous screws. Try to spare all his posterior muscles, and we had a good correction of his degenerative scoliosis. We maintain his lordosis, and we were pretty happy with the results. And well, so what comes next? So post-operative, his pain, his low back pain decreased to grade 2 on his VAS. He had an improvement on social and daily activities. After 6 months with a good fusion mass on his CT, he get back to fully training. And 1 year later, he returned to competition. This video is post-operative. So yeah, when we see him doing all these jumps, we get very scared of what's going to happen with his screws and his fusion mass. But he went back. Unfortunately, we had the pandemics. Tokyo was postponed for 2 years. He was already 36. And he was competing against the 20-something athletes in the Brazilian team. So he didn't make to the Olympic Games again, but he went back to the national competition. So you can see with the 2-level fusions, he's back to competition.
That's phenomenal outcome, man. Congratulations. And congratulations, you're just in time. That's appreciate that.
I just wanted to show this. Yeah, we have 1 hour. Okay. So I wanted to take advantage of the opportunity to bring on this book it's an ebook that was recently published last month by the spine team of surgeons I work with, and brings all these concepts of sports and spine injuries along with treatments. It is an open access in the web, but it's still only in Portuguese, although we are working on it's still in Portuguese, but we have the collaboration of international spine surgeons with huge experience in treating athletes, most of them from the United States. I also want to recognize the massive effort of my friend Michel Canas, who is here with us, in making this book happen. And we are already planning a physical version of it and an English version of it too, to our overseas friends to enjoy. If anyone wants to support our translation to English, please feel free to contact us. That's the QR code to access the book. If you want to try to read it, it's online, it's open access. So just take home messages. define if you're dealing with a recreational or a professional athlete to manage expectations. If you're dealing with degen of deformity, what type of sports you're dealing with, is collision, contact, non-contact. If you're dealing with scoliosis, your distal fusion level will be directly related to your return to play rate. Return to play is allowed if it's asymptomatic, there's a stable fusion, and he's back to all his playing capacity. Non-contact sports, 6 months is good. Contact sports, 6 to 12 months. Collision sports, 12 months or maybe not. That's very controversial. And educate patients about expectations before starting treatment. So yeah, that's it. That's it. Thank you, Alfredo. That's my email if you want to reach me. That's my hospital if you want to visit us. That's my Instagram if you want to follow me too. So yeah, thank you. Thank you, Alfredo.
I appreciate it. Thanks, man. You have 30 guys following up all the entire hour pre-involved. So
still there.
that was great. This session will be recorded in YouTube maybe in 2 days, so you can get it and go through it shortly. So thanks, man. Appreciate it. It was a phenomenal talk. A lot of research to do in this area.
Yeah.
So I'm very passionate about this topic. So thanks again for your kindness for this lecture. We'll see you, all of you, next week for the next session of Virtual Global Spine Conference.
Thank you. Thank you so much. Have a good day, good night, everyone, wherever you are in the world. And see you. Take care.
Happy Easter, everyone.